afternoon, everyone. My name is Dr. Ruchi, and I'm CEO at IHD India, an enterprise committed for social impact. With me, I have Ms. Madhura Gauri, who is the Associate Vice President of Indian Association of Respiratory Care. On behalf of the host organization, it is indeed my proud privilege and pleasure to welcome all of you. We are all going through the unusual phase of life, unusual phase, primarily the COVID-19 phase, and COVID-19 has played some.
Lot of echo.
Can you please, mute yourself? Those who are not speaking right now. Okay, great. So COVID-19 has placed unprecedented demands and pressure on the health system. Health facilities and workforces are diverted and assigned wide varieties of activities for controlling the outbreak. There is a growing concern and demand among the peoples and the citizens that the essential healthcare services are severely compromised in this phase. And hence, there is a massive damage to routine care in all settings, public and private. Now let's talk about the TB, leading infectious killer. Even before COVID-19, near about 10 million TB cases were there around the world. And with severe disruption in routine TB services, it is estimated that additional 6.3 million cases of TB we are going to add in the period of 2020 to 2025, which means there is a setback of 5 to 9 years of the efforts of ending TB. Now, if you see that UN, United Nations Sustainable Development Goals has this health targets to end this end this TB by 2030, but India has taken courage, an ambitious target to end this by 2025. Now, in the true spirit, IHD India and IARC has decided to have a deliberation to discuss all these issues, how India is ensuring to continue the TB care in COVID crisis. Today, we are fortunate to have eminent speakers with different background and diverse experience. Let me take a few minutes to introduce them before we start our main session. So our first speaker is Dr. Sunil Mehra, who is a founder and executive director at Mamta Health Institute for Mother and Child. Mamta is one of the unique development sector organization who is primarily work across the cycle of policy and practice. And that's why I think it's very important for us to hear the perspective what Mamta is thinking about, whether we are able to achieve SDG, especially the TB targets by 2025. Then we have, two speakers from government who will be talking about the 4 strategic pillars: detect, treat, prevent, and build. How they are ensuring these strategic pillars even in the COVID times. So Dr. Asha Frederick, who is a Joint Director of Medical and Rural Health Services National TB Elimination Program from Tamil Nadu, and Dr. Sunil Kumar, who is a State TB Officer, National TB Elimination Program from Kerala. And I think they are doing fantastic job as far as the best practices and learnings are concerned of TB care. Then we have Dr. Kamlesh Kumar Pandey, who is the consultant pulmonologist from Inspire Chest Clinic and Research Center, and who is a consultant at Wokhard Hospital. He will be giving us the perspective and the learning and the innovations what they are trying to do in the private sector. I think it is very important to realize that COVID has taught us more aggressively the significance of being digital. Now, since we are living in the technology, innovation, and pandemic era, so we thought to learn from ZMQ. Mr. Shubi Qureshi is there, who is the founder and director of ZMQ Development, to share what are the practical solutions they have been trying out to address and empower patients, who are dealing with TB, who are addressing the TB in the sector. Then we have Mr. Richard Featherstone, who is the senior business professional from Aerogen, a company that is dedicated to scientific excellence. So we would like to hear from him, what he's going to share about the future of technology development and how Aerogen, a company, a business company, and the technology company, how they are trying to address the issue of TB care in COVID times. I think sometimes we tend to underestimate the significance of public health literacy. And that's where I think we realize that we should also understand how public health literacy has a significant role in TB care in COVID crisis. Though we know public health literacy has shown, or was a part of a core strategy of slowing down the COVID infection. So it's a proud moment for us to hear Dr. Narayana Prasad, who is a founder of Public Health Literacy from Boston, USA. So currently he's not there on the screen, but he'll be joining very soon. So with this, I request my co-host and co-moderator, Ms. Madhura Gauri, to share her remarks before we start begin our main session. So Madhura Gauri, over to you.
Thank you, Dr. Ruchi. Thank you for a wonderful introduction. I'm happy to be here on behalf of the Indian Association of Respiratory Care, which is an organization for the young and dynamic respiratory therapists in and around India. IRC endeavors to promote excellence in the training and practice of respiratory therapy by competent and qualified respiratory therapists for the alleviation of suffering of those with respiratory ailments. Today's webinar is on how to ensure continuity of TB care in COVID-19 crises. India is a leader in morbidity and mortality due to chronic respiratory diseases. Tuberculosis is one such chronic respiratory disease affecting millions of patients in India. A couple of decades ago, only a handful of patients were infected by TB, while now it is one of the highest contributors to India's disease burden. Cities like Mumbai have become a nation hub of multi-drug resistant tuberculosis. TB has been a threat for a long time. It was once considered as an incurable disease, which became a potentially curable disease with new drugs which came in the later part of the century. Unfortunately, it is again tracing back to becoming incurable again. So, keeping this in mind, the government of India has announced its plans which eliminate TB by 2025. Unfortunately, the COVID-19 pandemic has added on to this threat and limited resources that we have to tackle tuberculosis. A joint effort by the government, medical practitioners, respiratory therapists, society, researchers at large, I think is essential to take control over the disease. And I think today's webinar was very much needed, and we hope that our discussions bring help about a change in the care of our patients in the country. With that, on behalf of the Indian Association of Respiratory Care, I welcome everyone for being here today. Let us move on to the deliberations of the seminar. If you have any questions, the audience, I request you to please post it in the chat box. We will try and answer them at the end of the seminar. Over to you, Dr. Ruchi.
Great, thank you so much, Ms. Madhura, and giving the perspective of IARC. And now I request our first speaker, Dr. Sunil Mehra, if he can share his perspective and thoughts on, can India eliminate TB by 2025? And coming from the, organization where they were the, part of the union, Akshay program, where you guys were implementing one of the largest program of TB care. So I think you are connected with policymakers as well. So you know the both perspective. So we would like to hear Dr. Sunil Mehra. Please, over to you now.
Thank you, Ruchi. Thank you. I don't know, I'm probably the most competent person in this group. I see all the great personalities around me. I'll try and do my best and be brief as much as I can. Let me say that I'm a pediatrician with almost 4 decades of the clinical practice, other than being the executive director of Mamta Health Institute. So I might add a bit of the pediatric perspective to your overall thinking, which I might like to leave you with. To begin with, yes, Mamta implements the community-based programs across 40 to 45 districts in one of the programs, which is the community-based, and in other 10 to 12 districts, which is city-based, working with the private practitioners. This brings the 2 angles to the story. The SDG 3.3 is talking about the elimination of TB, HIV, and malaria by 2030. The WHO in its statement says that 90% reduction in TB deaths and 80% reduction in TB incidence rate by 2030 compared to 2015 as the baseline. A tall order, but yes, India took up the challenge. I fully agree that this challenge is going to be further challenged with the COVID setting. Let us first talk about what do we need to do to reach that challenge. We have one of the biggest challenge, and that is the latent TB, the latent tuberculosis. With undernutrition, infection, poverty, that becomes much more relevant to identify the burden of the latent TB. Added to it is the health infrastructure. The last mile reach of the health infrastructure in many of the states, I will name them, is extremely low and extremely poor. Third, I think, which is equally critical, is the private sector. I think there are enough studies to say that private sector is somewhat not being as responsible for the tubercular treatment. And in fact, the private sector shows that 35% is one of the studies. The number may be questioned, that 35% of them who practice allopathy are actually not even qualified to be MBBS. And at the same time, 80 to 90% of primary healthcare is provided by the private sector. So private sector is going to be a very critical partner, and associations like a respiratory care association have to play a very critical role to see that private sector is there. Add to it is the poor nutrition and BMI, and COVID will further aggravate it, right? The nutritional crisis with the reduced income and poor access to the food grains, even if Government of India has done its best, is going to result in low BMI. Studies have shown low BMI prevalence countries have a challenge to address tuberculosis. The other element is being the indoor pollution. I think we need to think about this more carefully, and we are all talking about it in the present context. The indoor pollution is a big issue. On the other side, the factors like a tobacco consumption and the smoking are the barriers which and the prevalence of it may have gone down but hasn't gone down significantly. Lastly, what we say is the resources. Are we spending enough on tuberculosis? The UN data shows the commitment of about $1.2 trillion, which was made by the developed countries, is just giving half of its amount. So resources are going to be a big challenge to address the SDG 3.3 targets. Having talked about these challenges, let's talk about challenges which are beyond health and nutrition, which will significantly affect our achieving the targets. For example, the crowding, urban slums. Why should Mumbai be the hub for the multiple drug resistance to tuberculosis? Is slum and crowding one of the contributors? One of the contributors. I'm not saying the only contributors, right? The poor hygienic conditions, right? The homelessness, right? Are the social factors which are beyond the control of the health systems or public health policy parameters. So there has to be and above all, stigma, right? Stigma is something which is continuing and has a significant effect on compliance and early diagnosis, right? Early diagnosis has to do, to an extent, with stigma. And stigma, along with poor access to care and services, makes the matter worse for early diagnosis. We do need, in terms of the solutions, in terms of the molecular diagnostic, decentralized molecular diagnostic approaches at the last mile. And India is moving towards it, mind you. We are moving towards it. Secondly, I think the RNTCP program is now reaching everywhere across the country. The challenge is, again, to reach the last mile. It's the same ASHA, it's the same A&M which has to do this job, right? But in the end of the day, the strengthening of last mile along with private sector, actively engaged in partnership, as the previous speaker said, would going to be critical for achieving our 2025 targets. We may have to shift from 2025 to 2028 for our NEP targets, right? So in that sense, we are on track in terms of what we need to put in place. We know what we need to invest in. We need the political commitment. We need the resources. We need the state and district level coordinations to happen. And while implementing, one of the biggest challenge that we have seen is the reporting and honest reporting from ground, right? Till you don't get the honest data, till you don't get the real data from ground, you will never be able to see within yourself and make a critical investments in your programming. So collecting data from private sector, plus we have put the incentive programs, we have app applications for surveillance. I'm not going to go into the details, but still data is poor, mind you, right? So data would drive some of our likely outcomes that we want to achieve. Data is still very poor, and that is something which has to be quality assured as we move forward. Before I end, I would say, let me touch upon briefly on the pediatric tuberculosis. You cannot eradicate tuberculosis from India without being proactive. And as a pediatrician working in Maharashtra on zero pediatric TB concept with one of the corporate houses, we find that the infrastructure for pediatric tuberculosis is the poorest in the country. Even RNTCP recognizes this. Just making a statement from the WHO, let me read this. The burden of childhood TB in India is not known. Regional data from World Health Organization indicate that sputum microscopy smear positive TB in children under 14 years accounts for 0.6 to 3.6% of all reported cases. However, because the majority of children are sputum microscopy smear negative, these data are underestimate of the true burden of childhood tuberculosis. It is estimated that childhood TB constitutes 10 to 20% of all TB in high burden countries like India, accounting for 8 to 20% of TB related deaths. I know my long case was a hemiplegia by tuberculosis as etiology. That was in 81, right? And I'm saying that with a lot of emphasis that if the associations like you all partner with IAP and get to the ground, like simple things like gastric lavage is not available for children in many hospitals as a diagnostic tool. So maybe some of these basic measures need to be taken to make pediatric TB as an important element. And this is where many of the latent TB might carry on into adult tuberculosis, mind you, right? So it's important to reach out to the vulnerable children, screen them, diagnose them, treat them early. And it's very critical, right? And we must do it at the same time. Thank you very much. And thanks for this opportunity. Thank you for inviting. Thank you.
Thank you, Dr. Sir. Dr. Ruchi, would you like to say something? I think you're muted.
Yeah, thank you, Dr. Mehra, for giving us insight on whether India can achieve the elimination goal or not by 2025. And I think the critical issues which you have highlighted, that we know where to invest, we know what should be done, we know all this, but I think this somewhere the bottom line is the strengthening the last mile is the key. Unless and until we do that, we invest there and resources are utilized optimally, we are not able to achieve the goal of TV by 2025. The second thing which I think, which I really like and I've not much heard about is the pediatric TB. And that's where I think RNTCP or I think we will hear from the experts who are sitting here from government who will touch upon this point, what government is doing for pediatric TB. I think this is really good and enlightening to learn from Dr. Mehra about his thoughts regarding TB elimination. So over to you, Madhura.
Thank you, Dr. Ruchi. We will move on to our next session. Our next session is going to be a series of talks by various faculty. So our session is basically going to look at how state government RNTCP program is ensuring effective delivery of essential TB services and its outcomes in COVID times. So it's my pleasure to invite our first speaker for this session, Dr. Asha Frederick. Ma'am is going to talk about Tamil Nadu experience and best practices. She is the Joint Director of Medical and Rural Health Services National TB Elimination Program, Tamil Nadu. Over to you, ma'am.
Yeah, very good evening to everyone. Can you all hear me? Just say yes
Yes, we can
because
hear you.
I'm not very sure about the
Yes, ma'am.
Yes,
Go
we
connectivity.
can
ahead.
hear you.
Yeah. So, thank you for this opportunity and thank you for allowing me to showcase what we have done in Tamil Nadu during the lockdown. So, I'll straight away jump on to the share screening. Just give me the share screening.
Dr. Asha, I think your internet is not working properly, I guess. Dr. Asha, I think
I think internet
yeah, I think
connectivity is faster.
yeah, yeah.
Should we move on to the next session and come back to ma'am's session once she joins back?
Yes, I think we can.
Okay, fine. Let us move on to our next session. Our next session is by Dr. Sunil Kumar M. Sir is going to talk about Kerala state experience and best practices. He is the state TB officer, National TB Elimination Program, Kerala. Uh, Dr. Sunil Kumar, over to you, sir.
Good evening, all. First of all, I am thankful to International Institute of Human Development India for giving me the opportunity to speak on the experience from Kerala regarding TB elimination and how Kerala managed TB program during COVID period. Please share my slides. Please share my slides. Am I audible?
Yes, sir, you are audible.
Please share. Yes, okay. First, next slide.
Yes, Dr. Sunil, we can see slides.
Okay. When we are talking about the TB elimination of activity, we cannot ignore how the general health system work in Kerala. And we do have a strong general health system with the primary, secondary, and tertiary care. And this tertiary care service, and it is uniformly spread throughout the states of Kerala. And at grassroots level, we do have a
Dr.
sub-center
Sunil, you can
managed
speak.
by the
We can see your slides.
yes. Okay.
Yes.
Just an introduction only. I am talking. Currently, we do have a grassroots level general health system with a sub-center level uh, sub-center managed by the uh, multi-purpose workers as well as ASHA worker. There is one ASHA worker for 1,000 population, and moreover, the multi-purpose workers are don't change the slide. Now I am talking about the introduction only. So the multi-purpose workers caters the population around 5,000 to 6,000. They will be either male or female person as well as female person. And regarding the service, I told in the beginning that Kerala is having a strong general health system and TB elimination. TB program is well integrated with the general health system. That means the service is delivered even at the doorstep of the patient. That means sub-center level, the multi-purpose workers, they bring the service towards the grassroots level, so that all the patients are captured at the grassroots level itself. And during the COVID period, what we managed was we were having the service delivery at the doorstep of the patients, and so that they were getting the medicine regularly, and moreover, those who are having symptomatic symptoms were redirected to the nearest PHI through scooter pickup transportation mechanism. First slide, please. Next slide. When we are regarding the Kerala health structure, the Kerala population 14.1 million and IMR 7 per thousand live birth, and female literacy comes around 92.07, and systematic primary healthcare network, 1 ASHA for 1,000 and 2 multipurpose health worker for 5,000 population, and PSC for 25,000 population. Nearly 100% of the vacancies are filled. All the primary health centers are well equipped with the human resources. That is the major achievement of the health department of the Kerala, and a strong local self-government. Another most important thing that we notice is there's a strong intersectoral coordination with the local self-government, education department, labor department, Anganwadi ICDS program. All are well integrated, and they used to attend our monthly meeting also. And coming to the TB elimination program, as I mentioned, is integrated with the primary health system. And what a new structure that we developed for TB elimination is the District TB Elimination Board. It's a statutory body under the leadership of District Collector, District Commissioner, and it will have the representation of the political parties as well as the NGOs, as well as the other health department officials, and also the ICDS program staff, and also the people's representatives and Panchayat Raj members nominated by the respective Panchayat, and local self-government LSD TB elimination task force activities field level. They are form the task force, and for private sector engagement, we do have the steps system for TB elimination in private sector, and this was launched in 2019 in February in Kerala by the Deputy Director General of WHO, Dr. Soumya Swaminathan, and it is working very nicely. And moreover, during the COVID period, this acts as a pivotal agency between the public sector as well as the private sector. And coming to the present TB examination rate, Kerala, since the beginning of the program, that means when the entire country was covered under the TB elimination RNTCP program, that is in 2000 itself, Kerala, all the district covered under RNTCP, S2 RNTCP, and the present TB examination rate is highest. It comes around 1,400 annually per lakh population, and also the case notification TB examination rate. You can see the blue line, that suspect examination is going up, as well as the notification coming down. That orange color shows the notification rate that is dipping. Next slide. And what we notice, high case finding effort increasing at a rate of 7.5%, and low case notification declining at a rate of 3% annually, and private sector drugs sales declining at a rate of 10% annually. And we do have a system of cross interaction with the drug controller of the state of Kerala, where we will be collecting the data of the TB drug sales from the schedule H1 register maintained at the pharmacy, and from that we will analyze whether all these cases are notified or some are coming out of our public or private sector engagement. And the objectives of the TB elimination, Government of Kerala has launched the Kerala TB elimination mission, aligning with the Sustainable Development Goal, with the objective to achieve TB elimination by 2025, and zero preventable death due to tuberculosis in the state, and zero catastrophic expenditure for the families due to TB, and zero stigma and discrimination due to TB. Next. Action taken to mitigate the impact of COVID on TB services. And medicine delivered as I mentioned earlier, the medicine delivered at the doorstep. Medicine for comorbidity, diabetes, hypertension, hyperlipidemia, other comorbidities. A service offered toward the TB patient at their doorstep. And e-Sanjeevani, telehealth medicine, telehealth helpline in at all districts, so that the patient can communicate by telephonically with a concerned doctor or a field staff regarding their adverse reaction or whatever it may be. And e-Sanjeevani to manage the comorbidity illness during the COVID period, and telephonic follow-up of every case bi-weekly and this is a system and already in place in Kerala. Fortnightly clinical review, because majority of the death happening in Kerala in TB is due to comorbidities like diabetes, hypertension. So we ensure that the comorbidities should be addressed along with the TB, and fortnightly clinical review is happening at PSC level. District level clinical expert committee is already in place for the management of pediatric TB as well as the DRTB, drug-resistant TB, and IEC through social media that is unique in nature, and a constant review of troubleshooting and best practices documentation and facilitation of cross learning. And almost all the districts, the program indicators, determinants of the tuberculosis are analyzed with the support of medical college, the community medicine department, and through the STF mechanism. And coming to the COVID management, Government of Kerala issued the advisory notes regarding how to manage COVID tuberculosis during COVID epidemic. Next, regarding the trend of TB notification in Kerala in 2019 and 2020, you can see that we missed around, as in other states and other inter-country, we also missed around 1,500 cases remain undiagnosed in the community. Why? And we analyzed when the lockdown was introduced in March 24. First March and April, we were closely monitoring the activities, but we came to know that the reason for most often was due to patients afraid to coming to the primary health center, and moreover, the laboratory technicians are in a fear to handle sputum, and moreover, people remain close lockdown in their houses. And coming to the integrated algorithm for testing TB among influenza like illness and severe acute respiratory infection in the COVID-19 context of COVID-19, influenza like illness or SARI is subjected to rapid antigen test. That is a diagnostic algorithm, and if it is negative, it will be followed up by the advisory note issued by the Government of Kerala regarding the management of tuberculosis, and workup for alternative diagnosis if necessary, including chest X-ray if needed, will be taken for each patient, and refer to the SHOS is a state-wise program for management of chronic respiratory illness. Used to when it was called a PAL, practical approach to life health, and Kerala do have innovations to manage COPD as well as the asthma through the SHOS program, and also the vulnerable population that are prone to develop COVID were kept under surveillance. Age more than 60 years, diabetic, immunocompromised condition, malnutrition, chronic respiratory illness, chronic tobacco consumption, alcohol consumption, or symptoms, and patients with the symptoms that persist even after 14 days, and any abnormality in this chest X-ray, they will be subjected to CBNet or TrueNet wherever it is available. And at that time, the state was having the limited molecular diagnostic facility. Now we proudly announce that Kerala do have around 55 TrueNet missions and other around 32 CBNet mission. And from this month, then we will be able moving towards the molecular diagnostic facility in all the TUs of the entire state of Kerala. This TrueNet is supplied by the Central TB Division as well as procured by the National Health Mission through the NHS fund. And Kerala may be the first state to go for entire TU will be having the molecular diagnostic facility with the laboratory BSL2 facilities. for diagnosis of tuberculosis. Next slide. Trends of TB notification. This is all I mentioned. Next slide. Next. And a casual analysis identified a solution to find out the misdead TB cases. As I mentioned, that people are afraid to come into that already. I mentioned solution that delivery of diagnostic service at the doorstep, biosafety mechanism, our biosafety facilities at a TU level, and a strong ACSM campaign, provider oriented and people oriented. Next. Next slide. And the system one, the specimen collection and transportation. So the previous slide, sir. Previous. The system one, the specimen collection and the transportation. As I mentioned, that at subcenter level, PSC, the samples are collected with the ASHA worker, and it will be brought to the nearest PSC, and if from the PSC, it will be transported to the nearest TrueNat or CBNat center through sputum pickup transportation mechanism. This is integrated with other national programs for blood testing, so that it is a coordination of the RCH program and other national vector-borne disease control program. Next. Next, this is a molecular diagnostic facility currently that the state will be having, and the catch-up campaign October 2020 day, we launched the case catch-up campaign, case finding at the houses of vulnerable individual. Actually, during the TB elimination first phase, we mapped the entire state vulnerable population line list. Panchayat wise, it is available, and also PSC wise. And from this vulnerable population list, the patients are subjected to screening by sputum microscopy, TrueNat, or other molecular diagnostic facilities. Case finding among elderly and palliative care patients, case finding at old age home, destitute centers, screening for TB, ILA, and SARI cases. Next slide.
Dr. Sunil,
And this is the
Dr. Sunil,
Yes,
just
sir.
a request, because of the interest of the time, I request if you can summarize your presentation.
This is the last slide. The Honorable Minister
Sure.
of Health and Family Welfare launched the Access2Care project on October 2nd. And moreover, Kerala has moved towards the latent TB management. We came up with a latent TB management of pediatric cases by guideline, and this was approved by Central TB Division. And the first patient was put on latent TB INH rifampicin regime. The guidelines developed by Indian Academy of Pediatrician, and that was implemented. First patient was put on treatment last month, and we are planning to have the we are the first state in the country to have test and treat policy by IGRA testing. This is what the result all the ACSM activities, and Kerala started the activities a long time back with the airborne infection control measures to be adopted in the government hospital, as well as handkerchief revolution, and also airborne infection AAC kit is provided to TB patient to limit the transmission of the TB cases from the infected case. These are the innovations that Kerala has launched, and Kerala is in forefront in the latent TB management, and adult latent TB management we will be starting by January 1st, where we are waiting for the supply of the IGRA kit from the Kerala Medical Supplies Corporation. This is in nutshell the TB elimination activities, as well as the how the TB managed during COVID period. Thank you. Thank you, madam.
Thank you, Dr. Sunil, for wrapping up. And I think it's a great experience of yours, which really going to help us. So now we would like to request Dr. Asha if she's there. No. Dr. Asha, can you see? Dr. Asha, are you available? I'm not sure that. So let me then request Dr. Kamlesh Kumar Pandey, uh, consultant pulmonologist, to talk about how.
Just a minute.
Yes, yes, Dr. Asha.
Yeah, there's some problem with my connected. Share screen, I'm sending you the slide now. So once you let Dr. Kamlesh complete his thing, and then I think by that
Sure,
time
sure.
my connectivity issues would settle. Anyways, I'm sending you
Yes.
the PPT.
Sure, ma'am. Okay.
Sure.
Dr. Ruchi, can you hear me? Right? I can. Can you move on?
Yes, yes, please go ahead.
Okay.
Oh, yeah.
Okay. So
Thank
we
you.
let me introduce our next speaker. We have Dr. Kamlesh Kumar Pandey. I've had the privilege of working with him at the previous institution that we were working for. He's going to talk to us about how private sector is ensuring effective management and care for tuberculosis patients in the COVID-19 pandemic. Over to you, Dr. Kamlesh. Dr. Kamlesh, you're muted. So please, if you can unmute yourself. Yes, I think that's better.
Yeah, am I audible? Yeah.
Yes, yes, you are
Hello.
audible.
Okay. And the screen is there, right? Is the screen there?
Yes.
Yes, we
Can you
can.
see the PPT?
There's a slight time lag, but it's there. Yes, please go ahead.
Okay. So I'm here to share my experience regarding ensuring the continuity of TB services during this COVID pandemic. Now, I would be talking on three aspects. First is what is the impact of COVID-19 pandemic on TB services. Now, what challenges we as a private practitioners face during this pandemic. And then I'll just touch upon the measures which has already been discussed, measures that could ensure the continuity of care for TB services. So what is similarity between TB and COVID-19 is that patients have similar symptoms like cough, fever, and breathlessness. Both diseases primarily attack the lung, although TB has a higher incubation period and it's often slow in the onset. While experience on COVID-19 infection in TB patients remains limited, it is anticipated that people ill with both TB and COVID-19 may have poorer treatment outcomes, especially if TB's treatment is interrupted. Now, lockdown has severely impacted the access to healthcare services for TB. And also there's a social stigma and discriminatory behaviors against both the diseases, both TB as well as COVID-19. There's lots of social stigma. Uh, so WHO studied what impact COVID-19 would have on TB mortality. Now, the estimated death, which was estimated, would be around 1.47 million TB deaths. But if global TB case detection decreases by an average of 25% over a period of 3 months, an additional 190,000 TB deaths are predicted. Which would get us back this death was used to happen in 2015. So 5 years back we are going. And if the case detection drops by 50% in a period of 3 months, the number of deaths would go to 1.85 million, would be back to the level of 2012. So this is what COVID-19 is doing, impacting the TB mortality. Now, another good study published in Clinical Microbiology and Infection, modeling analysis has assessed the potential effects of lockdown on TB incidence and mortality in next 5 years in a country like India. Again, lockdown has resulted in a striking 80% reduction in TB notification rates. It is anticipated that a huge number of cases will remain undiagnosed and untreated, further fueling TB transmission rates among the household contacts. So in terms of MDR TB, considering an incidence of 5%, which is in our country, India will see an excess of 11,663 MDR TB cases per month during the pandemic. And even if we, in our private practice during March, April, May, we didn't get much TB patients coming to our clinics, even private setups. Not even in government setups, patients were not coming to the clinics. So there is a significant decreased number of TB patients attending the clinics. So there is a decline in the notification rates also. Again, data when compared to 2020, this study showed that routine BCG immunization data showed that in comparison to 2019, patients were less vaccinated with BCG in 2020. Again, considering the number of patients who had completed the DOTS treatment, again, we can see in comparison to 2020, there is sharp less number of patients who have completed the treatment in 2020. And also what we just discussed regarding notification also, we can see the sharp decline in the notification from March, April, May, which has picked up gradually June, July, but again, it is comparatively lesser than what it was in 2019, again suggesting that lots of patients we are missing, and we need to find those patients and treat them. So again, this was a very nice, large civil society-led survey on the impact of COVID-19 on TB epidemic. And what this survey found out, that 62% of patients currently on TB treatment felt that they do not want to visit their regular health facility because there might be COVID-19 patients and they can get infected. So they were worried. Now, among healthcare workers, 70% of healthcare workers felt that they were significantly lacking the personal protective equipment to safely care for TB and COVID-19 patients. 80% of them agreed that the number of people coming to our health facility and TB testing has decreased significantly during the COVID-19 pandemic. What about policy? 62% of policy and program officers felt that a significant amount of TB funding is being diverted for the COVID-19 response. Now, what the TB researchers felt, 75% of them agreed that they do not have the necessary resources to conduct important TB research during the COVID-19 pandemic. 85% of the civil society and advocates felt that there has been a significant decrease in TB testing during the COVID-19 pandemic lockdown. So again, this slide actually summarizes what is happening into the system. So what challenges we as a private practitioners faced? I also myself had lack of PPE. So in the month of March, April, I didn't get N95 mask. I was short of the N95 mask and the PPEs. And I myself had a safety concern. How will I ensure my safety for seeing the patients? So first was PPEs and safety concerns. Second is, what about the hospitalized, admitted patients? Private non-COVID hospitals were not admitting any patients with respiratory symptoms, and TB patients had risk of acquiring COVID at COVID setups. So again, TB patients had nowhere to go, neither government setup nor private setup. During this lockdown and that time, we did not used to do a lot of bronchoscopies, which we previously used to do to identify the culture, to identify the organism gene X, use the molecular test to identify the type of tuberculosis. So mostly we started that time patients on empirical or radiological findings, the TB treatment. So we missed a lot of drug-resistant TB cases, which during a normal time we would have picked up by utilizing the procedures, utilizing the molecular tests. So, and there was inadequate follow-ups and adherence issues and management of adverse events. For example, there was a patient who had deranged liver functions, and I had modified her AKT, but in March, and then she came for follow-up in July, and using the same 3 medications which was prescribed in the March, and we needed to reintroduce the medications once the liver function stabilizes. But this patient, because of lockdown, did not follow up. Again, there was another patient who continued to take all four drugs of first-line AKT for a period of 6 to 9 months, and he had severe joint pains because of one of the drugs, pyrazinamide. So again, not coming back, not following medications, not coming to the setups for utilizing their OPD care. This was a major challenges faced by patients as well as private practitioners during the pandemic lockdown. So again, so now I'll discuss what measures we could be done to ensure the continuity of services. Stop TB Partnership, which is an organization fighting to end TB, suggested certain measures like TB and MDR TB patients to stay home, utilize more of virtual care, multiple months of medicines can be given to patients, early procurement, careful planning of the local supplies. Now, another important point was shift to injection-free all oral MDR TB regimen, because again, for injection, patient has to utilize the healthcare resources, which was difficult during the lockdown. They suggested to start all patients on all oral MDR TB regimen. This was the same time when bedaquiline was available to our center, and we started initiating the newer MDR patients on the all oral MDR TB regimen. Family member can be identified as treatment supporter, so decreasing the burden on the healthcare providers. Virtual treatment support and digital adherence, telemedicine for managing the adverse events. Again, I trained one or two of my personal staff to counsel the patients regarding the adverse events, what is anticipated, and for which adverse events they need to come to us for reporting those adverse events. Managing context of these MDR TB patients. Again, community volunteers always needed. Again, here, Indian Association of Respiratory Care can contribute in a way to create volunteers to help TB patients continue their treatment at home by offering them virtual support, nutrition support, psychosocial support, economic support, connect to TB program, prevent the stigma and discrimination for TB patients. We can use online apps. Private sector again has a huge role in our country, as more than 50% of our people utilize private sector for their treatment. Again, there are certain other measures which could be taken for ensuring the continuity of TB services during this COVID-19 pandemic. Now, the first priority is to catch up on all the missed patients actively. So again, at Meera Bhainder, we have started active case finding survey where healthcare providers are visiting each and every family and trying to identify if any patient has respiratory symptoms or symptoms suggestive of tuberculosis. Innovative steps, software technology can be used for increasing TB notifications and contact tracing of both TB and COVID-19 patients. Utilizing the molecular tests like Gene Expert and TrueNAT again would help in early identification and treatment. Now, collection method is very important. Novel sample collection methods include drive-by sample collection sites, at-home collection by community health workers, and engagement of neighborhood private laboratories. So again, utilizing all different types of collection methods to ensure that patients do give their sample and ensure that they are identified and treated at appropriate time. Pandemic stress coupled with pre-existing stigma around TB has made matters worse for the patients. This has severely affected the treatment adherence in some patients, increasing the risk of drug-resistant disease as well as mortality. So we need a combination of intensive community engagement, maintaining awareness of the importance of TB services, and enhanced case finding efforts, including rapid scaling up of contact tracing wherever possible to compensate for misdiagnosis imposed by the lockdown. Again, here Indian Association of Respiratory Care can play a role in doing all these activities. Additional innovative approaches such as utilizing the digital technology and tools. TB patients often live in crowded conditions with poor hygiene, which increases their risk of getting COVID-19 also. It is thus vital that TB patients to be isolated to minimize the occurrence of severe co-infections in view of their depressed immunity and hospitalization. Such enhanced social distancing measures should be targeted more clearly towards those patients who have MDR TB, since they have more compromised immunity. So again, where possible, treatment support can be used by telemedicine as well as digital adherence. E-pharmacies can deliver medicines to home, so patients that can be tried. Community-based programs, based groups, including TB survivors, who feel they are much closer to the patient than the government staff, could be encouraged to provide patient support via WhatsApp, Facebook, mobile phones. Because injectable TB drugs were very challenging during the crisis, it is important to adopt WHO recommended all oral shorter regimen, which we also started at our center. To avoid big increase in pediatric TB, it is important to increase the BCG vaccination coverage and catch up all the missed BCG vaccination in the past 6 months, which we already saw in the slide that we have missed a lot of BCG vaccinations. Infection control measures like widespread use of PPEs, use of face masks, safe disposal of sputum, and physical distancing play a huge role in decreasing the spread of infection. Greater use of such infection control measures can help reduce the TB transmission. Again, as Dr. Mehra already discussed, malnutrition is a huge driver of TB epidemic in India, and India's economic collapse post-COVID-19 is pushing millions into extreme poverty and worsening malnutrition. So again, all government is doing a lot of effort by giving direct benefit transfers to the patients for improving their nutrition. So need to strengthen the public health system while simultaneously regulating and engaging with private health sector to deliver quality and affordable care would be crucial to ensure TB services during this COVID-19 pandemic. In particular, engagement of private healthcare sector is critical for TB, as nearly half of India's TB cases are managed by private providers. So again, summarizing the measures, what we can take is people-centered care, community-based care, which is more preferred by patients, and minimizing the number of visits to hospital, prevention and infection control measures to reduce transmission, rapid rollout of measures to minimize healthcare visits, WHO recommended all oral TB treatment for MDR TB, mechanisms to deliver medicines and collect specimens from home, effective use of digital technology, early diagnosis utilizing the molecular tests, and again need to strengthen the TB laboratory networks, TB treatment as per WHO guidelines, and digital counseling for improved communication, counseling, care, and information management. All these points could play an important role in ensuring the TB continuity services during this pandemic. Again, last line, what I would like to say is integrated effort from policymakers, from state and national government, and from non-governmental organizations is now needed to reduce the burden of TB by urgently maintaining continuity of essential services, accelerating surveillance of vulnerable population and asymptomatic contacts to identify high-risk groups. All these efforts together, we all need to come together, make these efforts to ensure the continuity of TB care during this COVID pandemic. Thank you.
Thank you, Dr. Kamlesh. You've given a good perspective of what it was like to handle and what it is like to handle from the private sector point of view. I think without further ado, let us move on to our next session. If you allow me, let me introduce the next speaker for today. We have with us Mr. Subi Qureshi. He is the director of ZMQ Tech Development, and he's going to talk to us about ZMQ ACTS model approach for TB as natural solution for COVID-19 and beyond. Over to you, Mr. Subi.
Hello. First of all, good afternoon, everyone. Good evening, and thank you for inviting ZMQ to share their experience. And I would like to thank both IISD and Indian Institute of Association of Respiratory Program for inviting us. And so just to give you a brief perspective, ZMQ is a technology for development social enterprise. We are set up as a not-for-profit technology company working in the area of designing technology-linked development solutions since 2000. We are almost 20 years in the domain, and we have been working around different health, education, livelihood solution. And TB, due to some reason, has become very close to what we are trying to solve. And I'll just share my presentation here. Screen share. So I hope, are you able to see the?
Yes, we can see. We can see, Shubhi.
Just a moment. I'll just put it up. So now, are you able to see the screen? Yes. So ZMQ has been in technology for development for some time, and we came up with this whole design model. So what I see in tuberculosis. Tuberculosis is one of the largest killer disease in our country, and moreover, in last 1 year, what we have seen, the way 60% of our case notification have gone down, treatment completion has gone down, just because of the reason that the patients are reluctant in reaching out to health services. There is also shift in the TB health service staff, which is more focused towards looking at the COVID scenario and the COVID program, and also a lot of shift towards COVID and neglecting many of the diseases, including tuberculosis. And we believe that there is a gap in the design model which existed all through the dots model, which is direct observation treatment short course, is so much top down that we do not build capacities of people on the ground to be able to understand and react and take control of treatment and TV and management. So I'll just take you to so we all know that due to as shared by Dr. Kamlesh Pandey, what are the key key areas that needs to be looked, and what are the key solutions that needs to be looked. It's pretty similar on the similar lines that we work. So we came up with a model called ACTS, which actually started with building tools for TB patients. But when we started working with TB patients, we realized that it's not sufficient. We need to build multi-layered bottom-up design model where we first need to build ground tools for people to understand TB. Unless we teach people what is TB, how it needs to be identified, how it needs to be looked at, how it needs to be followed followed up at community level, we cannot expect that the ground can take control of the thing. The second step is active case finding. Active case finding where patients are active in taking control. Not only the patients, but the ground, having understood the disease, they start proactively working towards identifying the disease at the grassroots level and start reporting or start seeking out for testing and related services. Then comes the layer of patient management, where patients are given control to manage their own disease. They are given tools to report adherence, and there is a need to change the protocol that a patient will be handed over medicine for a longer duration of time rather than shorter duration of time, switching from, like Dr. Kamlesh said, switching from vaccination based treatment to oral treatment regimen. So our first layer is called active ground building. So what we do in under active ground building at the grassroots level, we work with community radios, we work with community programs on the ground and build tools. So we are working in almost 7 aspirational districts: Mewar, Behraich, Baran, in Belgaum, Raichur, Mysore, Tonk, all low resource districts areas where we do the ground scanning and then build tools for communication, which are very very localized and powerful. We are building digital storytellers using local voice, local radios to produce animated stuff for the people to understand, which are run across communities, across schools. There is the introduction of TB as curriculum in the schools where we work. Then we once we have built enough knowledge and knowledge on the ground, we provision digital tools in the hands of communities and also in the hands of individuals to do self screening. And the self screening is about symptomatic screening. Algorithms are created, which are in form of talking tools, which talk to the community member, and they are able to find out whether they are TB. We have built an integrated self screening tool, which is both for COVID and for TB, so that there is no confusion with the patient that it could be a COVID case in a case or a TB case. And their self screening tools as well as community led screening tools, which are used by the community stakeholders on the ground. The third thing is that we provision a lot of tools not only for adherence reporting, because see, when we look at most of the technology companies, they're looking at gathering data. Nobody is looking at provisioning knowledge tools to the people, which is essential in ensuring that the community acts by understanding, not by, they're not forced to give data, or the data is collected from there. So we design tool which talk to them in their local language, and it can be consumed by even semi-literate or illiterate, because they are audio visual in design. So they talk to, for example, simple example is that every morning when you have to take there's an alarm that will ring, and then it will start talking in local language that दवाई खाने का समय हो गया है, and then it will become harsher over the period of the day. So a person will have to act, and they're given and they're given choices to report. It could be audio based reporting, video adherence, which is the best in terms of reporting using evidence based video of short 10 seconds or 15 seconds, which is said by the patient himself or herself. So here are some pictures. So we are working in Africa. We are building the whole active compliance platform for East Africa. At the moment, we are in almost 12 districts in Africa, but in India, we are present in 8 districts. We are in our active compliance tools for patients adherence reporting is integrated to a national TB program as well. It was tested in 8 districts recently. So this is how they do, and this is just some of the pictures from there. So this is like community-led supervision or community-led adherence reporting and supervision, where somebody from the community or the family is trained to do that. So we are opening up the whole barrier of TB at the community level. So what it is doing is it's also reducing stigma at that level. You are not doing a top-down approach where you are asking somebody not to share information, keep quiet, hide, and don't talk about the disease, or people generally hide away and shy away from sharing their status of the disease. So, but active makes it more breaks the barriers of so where we have community volunteers, and they use basic phones to smartphones, all kinds of phones. It works. So this is a boy who leaves early morning for school. Before that, he ensures there's a mother who cannot handle a phone reports her adherence daily. So this is from Uganda, where a family member is supporting one of the patients. So we are building all the tools for the DMCs, for the STAs, so it's all active. So you can see real time status of what is happening on the ground, how people are reporting, and so this is the fifth layer, which is called active treatment management. So that the focus of the infrastructure is to deliver best care rather than be hunting for patients, be running after patients, be ensuring that docs is happening on the ground or not. The last layer of this whole design is called active ground assessment, which is basically AI layer which scans the performance of every spatio-temporal level, every space, and then does recommendation for what needs to be done on this particular ground. So every ground will have its segmented approach of managing tools. For example, the e-prediction and forecasting tool will tell us that this ground needs more focus on pediatric TB, and there is another ground which needs more focus on TB in women or TB in general. So it will give you very specific, recommendation about what needs to be done, so that we do not, burn our resources equitably on all grounds alike. This is for this purpose. So I'll just take you through two of our recent programs that we are doing, and one is around integrated approach of building. We have a program called Mira, which is a digital last mile healthcare tool for ASHA workers. We call them Mira workers, who cover 1,000 population, and they have each household registered, and they are using that strategy, and further tools of screening are built on their devices, so they are using the entry point of a pregnant woman or a woman in a house to excavate opportunities to find TB at that level. And we are working this in Mewat right now. This is a program which is supported by Stop TB partnership Wave 7. So we will be probably extending this for another 1 year. And the second program, we recently won a grant from Johnson & Johnson, where we have brought in a new tool into our system which is remote consultation, so that and it is for DRTB patients, so that the patients can access doctors to for consultations at any moment of time. So they have access to, because for DRTB the treatment regimen is long and it is cumbersome and it has a lot of side effects, and we always had this problem that patients um, and we recommend that patients should be doing it from their home, so that they do not come out to the centers in the time of COVID. But see, COVID has shown us the path. See, COVID has COVID. What we say at ZMQ is that, see, COVID has been a very great equalizer in terms of demonstrating to the world that how should we be reaching out to the last mile communities. It has shown that digital connect is a resource in itself. It's not just a means to do it, it's a resource in itself, and we need to redesign all our healthcare solution with a bottom up approach rather than top down approach. We saw during the COVID time how the top down approach failed and collapsed. And it is time that we need to redesign everything bottom up, so that we give control in terms of knowledge, in terms of identification of cases, in terms of management of cases, and so on and so forth. Rest all the technologies will keep falling in place if we design it bottom up. So my last thing would be that we do a bottom up design model. We'll have to rectify if we have to meet the targets. We will not be able to meet the targets unless we do rectification in our design models. Thank you.
Great. Thank you, Mr. Shrubi Qureshi, for giving us, understanding of the significance of bottom line design models for empowering patients, even in the COVID times and beyond. So now I think, so thank you for that, Mr. Shrubi. Now we have Dr. Asha. Are you ready? Should we share your slides? Can we?
Yeah, can you hear me? Yeah,
Yes, we can
share
hear
the
you. You
slide.
can start. We are
You
sharing
can
your
share the
slide now.
slide so that I can start here.
Sure. Yes,
Yeah,
slides are
thank
visible
you.
now.
So good evening, and sorry for the change in the agenda because of my connectivity. So let's move on to the first slide. So this is regarding how it all started. The first case was in the March of 7th, and the lockdown was announced by March 25th, the very next day after the World TB Day. And the first extension of the lockdown was till 17th May in Tamil Nadu. Then after that, then again it further extended. It was just to take you back to that scenario. Next slide, please. So we were able to identify gaps during this time, the very first month in April and May. So we could find a notification, the presumptive TB examination came down to such an extent, it fell down to almost 1/3 of what it was in the previous years. And of course, there was a lot of NPY DBT rejections, which was inherent to the NICSHI as such. And of course, because of the lockdown, our contact tracing activities also took a hit. But there was also a gap that was identified in the NICSHI online registry completeness during this time, because most of our workers were also involved in the COVID duties. Next slide, please. So the first area, once we identified the gaps, we thought we would intervene at each area. So the area first was diagnostic access improvement, because we knew once the lockdown was announced, it was difficult for people with symptoms to access the health facility, and also most of the health facility was closed down, and only the half of them were working because of the diversion of doctors and things like that. And the second area of intervention was to drug delivery improvement. Third was notification improvement. Then we also needed to, during the lockdown, patient monitoring and reporting became a huge challenge. Then we had to support the patients, and we knew that we have to strengthen this particular system. And all these have to be reviewed. And again, as we earlier identified, NICSHI completeness review and updation was very much part and parcel of the entire area of intervention. The next slide, please. So diagnostic challenges and how we had to, what we did to improve this. So movement between facilities, but and allocation towards COVID activities. So as I said earlier, so most of our human resources, our STS, STLS, the lab technicians, all of them were diverted for COVID duties. Now we also had problems with sample transportation. As you know, Tamil Nadu has achieved 90% in the universal drug accessibility testing. So we ensure that every sample that is collected, that is a positive, gets tested for CBNAT and first line LPA. So this was a huge setback for us once the lockdown was issued. And of course, we have two IRLs, one in Chennai and other in Madurai, and also to Pondicherry. So we have around 38 districts, and all these districts are, the samples go to each of these IRLs. So the distance was there. So what we did was to first strengthen our own HR. We issued everywhere the travel pass from the headquarters. So we saw to it that this was facilitated to every HR. And what we did was pooling of samples. So from 3 or 4 districts, the samples would be pooled, and we have our own NTEP vehicles. And from those vehicles, it will be transferred to the IRLs, the nearest IRLs. So this is what we did to achieve our universal DST. And we did this utilizing our NTEP vehicles. Then also what we did was we could not enter Pondicherry because of strict lockdown there. So we redistributed the samples towards to our own IRLs. We also facilitated doorstep collection of samples. So what we did was we would call the patient, and we would ensure that the samples are, because we will not allow the patient to travel, rather by issuing travel pass to our own STLS or LT, we would ask them to go and collect the samples at the doorstep of the patients. So next slide, please. We did this for follow-up patients on treatment. The following mechanisms are also followed: doorstep collection and OPD referral for laboratory collection, which is an ongoing process. So, and as I told earlier, what we did was redistribution of culture and DST district linkages and pooling of samples. Next slide, please. So the next slide. So this is how I told you the number of districts that we had. So what we used to do was from three districts, the samples would be collected the day before. It would be brought to one district, and from there it would be transported to the intermediate reference laboratory in Chennai. Then we distributed to the Madurai lab. Three districts were pooled. The samples were pooled. It would be stored in the walk-in coolers that was available in the major microbiology department, medical colleges. And from there, we would use our own vehicles to transfer it to the intermediate reference laboratories. Next slide, please. So again, this is a map that is showing the distribution of the lab linkages for culture and DST for offering universal DST to all the patients during the lockdown. Next slide. So the drug logistic management, because we knew once the lockdown was issued, there would be patients will not be able to come to the PHSI to collect the drugs. So what we did was, again, we followed a doorstep delivery strategy. And we also have this NICSHI Sampark redressal system is already available in the program. And we had many inquiries through NICSHI Sampark desk as well for medicines from the private patients, from patients who had traveled from Bombay and even from abroad. Next slide, please. So ATG drugs are delivered at the doorstep or advised by to be collected from the PHI close to the patient residence. So mostly what we did was we used to call the patient and ask if sometimes they would there was one issue here. There were patients who were taking medicines without the knowledge of the family because of the stigma. So we also ensured that nothing untoward happens in the home front. So we used to call the patient. We ensured that the health visitor calls the patient and gets an appointment of the patient, ensure that they are available in their houses, and we delivered the drugs. The next thing was telephonic monitoring of drug intake. So once what we did in by the first week of April, there was a circular that was issued to all the public sector facilities, to all our own district TB officers, to give medicines till the end of May. May 30th. So we ensured that 2 months drugs were delivered to the patient. So how do we monitor? Monitoring and supervision is very essential, because these are directly observed treatments, but it will not be monitored. So what we did was, we at the state level, we started doing telephonic monitoring of drug intake by the patients, and we also supervise the same by directly calling the patient and ensuring that at what day our STs arrived to issue drugs, and how many doses they have, what is the period of the follow-up sputum that is to be collected, have you informed that your follow-up sputum will be collected. So these sort of questions were asked, and also we ensured ask questions about adverse drug reactions to the patients, and sorted that they did not suffer from any ADRs and because these were unsupervised doses. So that was about telephonic monitoring. And we also scheduled the delivery of drugs to districts from the SDS. So we have two state drugstores, one in Chennai and other in Trichy. And from here, we had hired vehicles, and we saw to it that every district TB center had its enough and more about the buffer stock, because we were giving drugs for the patient at bulk drugs were issued. So the next one was, upon Nikshay Sampak redressal request by respected TUs also, we used to address. And ATT was also delivered to State Drugstore Andaman and Nicobar Island via PCI shipment. So there were requests from Andaman and Nicobar, because they were also running short of the FDCs, fixed drug combinations, and we were able manage to catch a shipment and send it across to Andaman and Nicobar. Next slide, please. So this is regarding the circular that was issued from Tamil Nadu to all the district TB offices. So a total of 40,807 patients at that time. At that time, the live patients were issued medicines by the second week of April, once the lockdown was started. Next slide, please. So one interesting thing was, this is treatment support services. So you can see all our STOs going and giving the drugs to the patient, and also some of the samples, sputum samples that will be collected from the patients. Next slide. So this is an appraisal from one of the patients, pre-XDR patient from Mumbai, stuck in district Ariyalur, which is in central Tamil Nadu. They were provided by 1 month course this was through Nikshay Sampak grievance desk. Next. So case finding, notification strengthening, this was the third area. We found that OPD turnout was very less. Now we could not do ACF activity, active case finding, because we cannot ask the patients to come in groups, and there was also apprehension among the healthcare workers. So what we did was, we did a targeted case finding. We formulated a small format and an algorithm, because we already started having this SARI and ILI patients that were flowing in because of COVID. And we passed circulars through a Clinical Establishment Act a leader who is the Directorate of Medical Services for strengthening the private notification and for targeted case finding, and instruction from the state to procure PPE from district budget, and training on rational usage was also given to the field staff through video conferencing. Next. So this is our TCF algorithm. So the severe acute respiratory illness patients were all admitted in the facilities, whereas the ILI patients were, like they were in the COVID triad centers. So we, whoever were offered COVID test, there, if the COVID test is positive, we would ask them to encourage them to go for a sputum CBNAT and X-ray. And if the COVID test is negative, we would ask them to do a CBNAT. So we asked we gave training through VC, and we asked, because some X-rays, they were COVID were all, it was all mimickers. It would, mimic TB. So we ensured we trained each and every through video conferencing, and we asked them to do the TB testing for all the SARI and ILI patients. And there was another approach, which was a community approach, and we also asked questions like we gave them the case definitions, and we had trained them how to collect the samples. Next slide. So, and we had mobile X-ray units. This was the initial plan because we could not do an ACF. This was the initial plan to send the 14 mobile X-ray vehicles across Tamil Nadu for screening. But later, what happened was these mobile X-rays were put in various places in the COVID triad centers. So once the X-rays are taken for patients, there were some districts that also used artificial intelligence to narrow down to some of the diagnosis, and then it would be read by the district TB officers in Tamil Nadu. All the district TB officers are chest physicians. They have a diploma in TB and respiratory diseases. So thus X-ray were read. So we used to get X-rays from the COVID patients, and also used to get X-rays from the TB patients. So these 14 mobile X-ray vehicles were optimally used, and even now, even after the lockdown has been lifted, there are some districts which are refusing to return it to the program for ACF, and because they are still having inflow of patients in the COVID care centers. So these X-ray vehicles are still stationed in some of the CCC centers. Next slide, please.
Dr. Asha, I have a request, Dr. Asha, because I think we are completing our time and we still have to. So can we come to the concluding slide?
Yeah. So
yeah, if you can talk about concluding slide.
Yes, patient monitoring. Just go ahead, then go to the next slide. Yeah, this is about telemonitoring. I already told what we did in telemonitoring. Next slide. So yeah, this is just to tell you, in DSTB the symptom relief was just to show you what was the thing from the telemonitoring that we had. Next slide, please. So patient support system, I already, when we called the patients over phone, there were some patients who told us that they did not have any livelihood because of the lockdown. So we were able to provide them nutritional support. So this telemonitoring helped us not just clinically, for adverse drug reactions and all that, but also to help patients outside, provide them psychological support, nutritional support, and things like that. Next slide. So this is the nutritional support that was offered to the patients. Next slide. And during COVID, we did all the review of activities through virtual things. Next slide. You can see a district TB officer conducting a review meeting, maintaining social distance in an open air. Next slide. So this is the video conferencing mode of virtual review meetings that we're using Zoom platforms. Next. So Nikshay complaint review again through VC we did. Next. COVID collaborative activities again through VC. What we did is bidirectional COVID screening. We asked everybody, as I said, the SARI and ILI. So that is the first TCF activity. Next slide, please. So this is the challenges. I think we can stop with this because almost now that lockdown has been lifted, most of the challenges have been resolved. So I thank you, and once again apologize for the poor connectivity. That's because of the rains here. Thank you so much.
Thank you, Dr. Asha, for sharing what Tamil Nadu has been doing. And I think we really like the strategy which you shared about the doorstep delivery strategy. That's how I think you are ensuring, and other states can also hopefully replicate the strategy. Now, in the interest of time, I just quickly request Mr. Richard. Richard, are you there?
Yep, hear you loud and clear. So can you put my presentation up on the screen, please?
Yeah, Richard, your screen, you're sharing the screen. You can start.
Yeah, can you hear me?
Yes, we can hear you.
Okay, could you put my slides on the screen?
Yeah, I think. Can you see the slide?
Yeah. Okay, lovely. So next slide, please. Okay, so next slide. Oh, no, sorry, a bit too far. Okay, so nebulizing medication for respiratory compromised patients has been a technique that's been done for many, many, many years. But obviously with the onset of COVID, that technique is now come under question. And the reason for that mainly is because most nebulizers are jet nebulizers and they require a drive gas to make them work. The reason why this is a problem is because we are concerned about the amount of aerosol that comes out of the patient as well as the device that potentially can contaminate staff and other patients. So we tend to look at aerosols in two ways. One is the medical aerosol, that is the aerosol that comes out of the nebulizer. And for all intents and purposes, that should be uncontaminated. And a lot depends on the design of the nebulizer that's used. The worrying aerosol is what we refer to as bioaerosols. And this, of course, is if a patient has COVID-19 and they're laughing or talking or singing or whatever, then that bioaerosol with the viral component in it is the one that we're most concerned of. So next slide. Okay, so the technology that Aerogen have pioneered is vibrating mesh. Now, this technology has been used in India for some time. The reason being is because you will get something like 6 times more drug getting into the lung. And the reason for that is that the vibrating mesh creates very, very small particles down to 3 microns, which means that that drug goes right into the lung where it's required. But in the COVID patient, this actually works even better because the system is designed not to be taken out of the circuit and that you can refill it without having to disconnect. And we call that a closed circuit. So next slide. Now, because of this, a number of quite eminent institutions over the last year have issued guidelines, including 2, the ICS and the Critical Care Society in India, who have both looked at all of the data, and all of these institutions have basically said that using vibrating mesh technology in a closed circuit in intensive care is the way forward in the COVID patient, which is good. Next slide. So what does it mean, closed circuit? Well, we're referring to patients on an intensive care ventilator, which is probably where you don't really want to have your patient go. But you can see on the left here that this technology using the old jet nebs meant that when you wanted to refill the device with more drugs, you actually had to disconnect it from the patient's circuit. So if the patient is having COVID-19, the chances are that that contaminant is going to get into the space, the airspace around the ICU, which is of course great danger to the staff and other patients. Whereas on the right, on the closed circuit, the vibrating mesh nebulizer sits in line in the circuit, and if the patient requires more medication, then it's quite easy to refill it and turn it back on without having to disconnect it from the patient's circuit. So any contaminant stays within the circuit and is not spread into the air. Next slide. Okay, so that's great for intensive care patients on ventilators, but there are a lot of COVID patients that require respiratory support that don't, hopefully, need to get onto an intensive care ventilator, a mechanical ventilator. And one technique, one respiratory technique that's now been used quite extensively in India as well, I believe, is the high flow nasal cannula system that delivers a very high flow of gas to the patient via a nasal cannula. But again, because of the risk of COVID, a lot of these techniques have been put on the back burner purely because a lot of physicians are worried about contamination. But here in this study, what they did was something really quite simple, and that was just to place a face mask, an ordinary surgical face mask, over the patient's face to cover the nasal cannula. And by doing so, we're able to show that the amount of dispersion of COVID into the air was less than what you would find typically on a standard oxygen mask at a much lower flow rate. So that bodes well for this technology and hopefully will encourage more physicians to utilize it. Next slide. I bring this slide up here. This is the ICS guidelines, and the two elements at the top basically support what I've said about using vibrating mesh within the mechanical ventilator scenario in ICU. But the bottom part is probably of most interest to your listeners today, and that is that a lot of patients require drugs to be nebulized, but fortunately won't go anywhere near ICU. However, they've still got COVID and you still have the risks of using a jet neb. So in the ICS guidelines, what they suggest here is using a vibrating mesh nebulizer, but importantly, using it with a mouthpiece rather than a face mask. So if the patient exhales, then any contaminant matter doesn't go into the air, but stays within the system. And most importantly, they put a filter onto the end of the mouthpiece to take out any viral matter. So my last slide shows you what it looks like. So next slide, please. So you can see here, the setup is quite straightforward. So because the vibrating mesh doesn't require a high gas flow to make it work, it means, and it's electronic, of course. So what happens is the drug stays in the chamber until the patient inhales. And then when they exhale, there's a simple connector, and then there's a viral filter on the end of the mouthpiece, you can see here, that will take out that particulate matter, and that can be disposed of. And the research that's looked at this said it's quite an effective system. So a lot of information to cram into a very short presentation, but I realize we're running out of time. So I thank you all for your invitation to speak today, and thank you very much.
Great. Thank you so much, Richard, for completing your presentation on time. And I think it is really delighted to hear that ICS guideline has given clear indication of jet versus mesh nebulizer, and mesh nebulizer is much more preferred in the COVID time. So thank you for sharing, Richard, on this. And I think audience will like to learn more on your website, or it's all available in the public domain. You can read that. Then I think we have a last presentation, and which is again another significant and important presentation about the public health literacy. And Dr. Narayan is with us from Boston. I think it's a morning for him. So, Dr. Narayan, can you please share your perspective, your thoughts about public health literacy, its significance in COVID times, and particularly for the TB patients? So, are you sharing your slides? Dr. Narayan?
Yes, I am sharing my screen. I will take this. Give me 1 second. Let me just get.
Great.
Great. Can you see my slide?
Yes, I think it's coming up. Yeah. Yes, we can see your slide now.
Great. Great. Thank you. Rishi, thank you for inviting me, and it's a pleasure to be part of this group. Uh, Being the last one, as both good and bad, the good is the best news has already been, best information has already been given to the audience. The bad is, I guess, most of stuff that I wanted to share has already been shared. So let me see if I can manage next 7-8 minutes to get my message across. So public health literacy, and perhaps a very emerging topic. We need to address this during COVID and TB convergence of this generational crisis. I want to thank Dr. Priyanka Mangani, who has helped me in putting these slides together. Health literacy and public health is a very broad word, and we know that literacy is all about accessing, understanding, appraising, and applying health information to make the appropriate choices, especially during COVID and tuberculosis crisis that India has been going through. It is divided in 4 different sections. If you look at this slide, and you can understand each one itself is a massive project one can take of understanding the information, getting the information across, making sure it's the right information to get across. Now, some data on this, and there is a lot of data, such research has been done. Low health literacy costs a lot of money, both at healthcare system level. This was done by 3 different studies at Switzerland, the United States, pretty large sample size, staggering economical cost to the healthcare system, which is the institutional level. More or less, almost 3 to 10% of the healthcare cost is purely attributed to the low health literacy. At the patient level, several research, this is an empirical research review that has been done, consistently showed having low health literacy costs high to the patient level economically. Now, then we come up with this whole social media sensation, which has brought instant access to the information. We are all blessed to have this kind of digital access, but it also has introduced a major credibility on the information, which most of the speakers have already shared. How do you get the message across? How do you control the misinformation? The Lancet recently published an article how health literacy is a massive underestimated problem during COVID. MIT published a very good article on Twitter, about Twitter, that lies travel 70% faster than the truth, which means more fake it is, more false it is, there is a higher chance of you retweeting it and reaching out to the larger audience, disseminating the false information. That relates to our stigma and all the other stuff you have been sharing in the last hour or so. Probably it's a human-driven problem. Tuberculosis, as most of our speakers have shared in the last hour or so, it's a combination of 2 infections, one coming from the virus, one coming from the bacteria. One has been sitting as a big elephant in the house, which is tuberculosis. COVID is just an instant attack on mankind, but both have the same symptoms: cough, fever, and difficulty in the breathing. At least from a public perception, those are the 3 things we should end up educating our common civilians. So India lockdown, I think some of the speakers shared it, that there is an 80% reduction in tuberculosis notification rate. And there is a disruption in entire supply chain system. When I say supply chain, I'm talking more on an economical and a political and healthcare delivery system combination of both. It's a human capital reduction because everybody is staying home. There's a supply chain of delivery and fear, and even end users who are patients who are also disrupted because there's no proper chain that was in place to protect and also prevent tuberculosis spread. Disruption is essential, essential health services, especially people who are suffering from tuberculosis. There was some data recently I read, and I've cited in the last slide. The COVID crisis has literally wiped out 5 years of accomplishment in TB eradication success in our country. Some numbers and death due to disruption in case detection, which is major disruption, could result in additional 400,000 lives. And as again a repeat slide, additional 6.3 million cases could happen due to quarantine and lack of services. And we also expect 1.4 million people dying from over the next 5 years from tuberculosis. The disease burden, this is from Imperial College London. She said it very well. The ballooning of the TB burden is because there has been missed opportunities both for diagnosis and people have not been able to present for the care. That's a self-inflicted low literacy consequence. So TB and COVID, we have been talking about that, and there is something parallel, co-variable parameters that are actually facilitating this crisis: overcrowding, poverty, pollution, and diabetes. If you put all those four together, the COVID and the tuberculosis has been the worst recipients of the crisis. The numbers don't lie. There is 10 million COVID cases and 10 million annual cases of tuberculosis. Imagine the overlap and the massive human damage in our system. So it brings back to very important topic where public health literacy plays a big role. How do we control misinformation? What information is reliable? How do you control disinformation, misinformation, malinformation, which actually leads to disturbing catastrophic thinking and could also lead to unrealistic optimism in some population who believe just staying home could be a better choice than seeking appropriate care due to the lot of fake information that's going around. This one, especially the Harvard Kennedy School published an article recently, which was originally generated by John Hopkins Bloomberg School of Public Health, how health literacy itself is a public health crisis, how it should be included, especially by healthcare professionals. They must acknowledge and prioritize importance of literacy at every interaction with patients and communities. It has to be a critical part of their care delivery, educating the end users in the communities. So some of the key things which has already been touched upon by previous distinguished speakers is where does public health literacy can play some role? How do we get reliable and accurate information on COVID and at-risk patients? You could start using telemedicine services and credible online notification portals. So this is a downstream public health literacy, but in upstream, collecting credible data of this implementation and kind of developing predictive analysis of what worked, what did not work during this process is an area that has been not addressed. Did we learn from something by implementing these amazing initiatives? Information regarding medication access and the delivery, and the destigmatizing about COVID and tuberculosis. I mean, the stigma between COVID and tuberculosis are completely different. It's not one size fits all. In my own family, the perception of COVID and tuberculosis varies, and I have 50 members in the city of Bangalore. Each one presents to me with different opinion, and most of them are stigma. So that variation must be teased out, and somehow public health literacy should intervene to help mitigate that stigma. And a big scope of it, how does literacy can work? And this is a framework. If you do early diagnosis and treatment, you could by impacting health-seeking behavior, by teaching medical compliance, you would reduce the mortality. By preventing tuberculosis spread, by implementing healthy living. And most important, literacy can also influence social behavior change and communication, which is mostly developed by local champions. And hence, it will lead to a larger capacity building at a grassroots level instead of coming from tops down, as one of the speakers said. Health literacy has to be bottoms up. And that is what I had in my mind. I do want to give some time for question and answers. I know I was the last speaker. We are all running out of the time.
Great. Thank you, Dr. Narayana, for giving the significance of public health literacy and a lot of literature which you have shared. I think it's going to help our students who are, watching us, especially. And I think something which I will like to take from your presentation is that PHL can mitigate stigma, and stigma is something which government and policymakers were trying to address during this journey of, outbreak. And and then the one thing which also very interesting, which you highlighted, is that stigma is very unique for TB and it's very unique for COVID. So this is also very interesting. It's not that one size fits all. So thank you for highlighting these points. And due to time, I think that we have already completed our time of the session. We are not taking any questions, but I can see there are some questions which are they are asking, and maybe we can share with all the speakers those questions later on, and we can respond to them. So now, the last, I think the concluding part. So we have learned a lot from different speakers, and I think this is very clear with today's deliberation that effective and rapid response to both COVID-19 and TB treatment and management services should run simultaneously. And I think after hearing government as well as the private sector, we are clear that there is no break in the continuity of essential services for people affected with TB during the COVID-19. So with these remarks, I request my co-host and co-moderator, Ms. Madhura Gauri, to present vote of thanks to our wonderful eminent speakers, and of course, all the audience who are watching us. Over to you,
Yes.
Madhura.
Yes, thank you, Dr. Ruchi. Thank you, everyone. So let me make this really quick. So on behalf of both the organizations, ISD India and IARC, I would like to thank all the speakers who spent their time from their busy schedule to grace this occasion today. Today we had the opportunity to learn from your expertise, which is very encouraging for our future deliberations. We are truly honored to have you all here. Thank you, Dr. Ruchi, CEO of ISD, for taking the lead in conducting, hosting, organizing today's webinar. We have been fortunate enough to be backed by a very proactive and dedicated organizing team working behind the scenes to make this event happen, especially the technical team that is currently there behind the camera. So I would like to thank everybody. We appreciate your support. We look forward to continuing this drive for better healthcare in India. And with that, I hope to see you all again. So thank you so much.
Thank you, Madhura, and thank you so much to IARC. And thank you, everyone. Have a great weekend. Thank you.